in our fight against cancer. Capable of precisely treating diseases while protecting the patient's health, proton therapy also requires a strong team to support it. With everyone performing their duties and working persistently over time, the radiation oncologist is more like the captain of a ship. Where the ship should sail is determined by this doctor. Medical physicists are the behind-the-scenes workers in proton therapy. They play two important roles. One is the designer of precise radiotherapy, and the other is the guardian of safety and quality. Every precise irradiation of proton therapy cannot be done without the therapist as the executor. Nursing is the safety guardian and warm service provider throughout the process. From admission to discharge, case managers accompany them all the way. Patients all say we are the people they are most familiar with in the hospital. Of course, whether the ship can reach our destination is not decided by the doctor alone. We also have our physicists who are more like navigators, just like calculating the route based on our doctor's orders. And our therapists, they are more like helmsmen, operating the machine to deliver precise treatment to the patient. We also have our nurses and case managers, who act like an escort to safeguard our patients so they can successfully complete this proton therapy, working together as a whole to deliver several precise treatments to the patient. Medical physicists are the behind-the-scenes workers in proton therapy, and they have two important roles. One is the designer of precise radiotherapy, and also the guardian of safety and quality. The radiotherapy designer is responsible for designing each radiotherapy plan, dose calculation and optimization, maximizing tumor control and protecting normal organs. We are also the guardians of radiotherapy safety and quality, performing periodic checks on the radiotherapy machines to ensure the precise operation of the machines. The process of radiation therapy is usually divided into 5 steps. As for the therapists, they are mainly responsible for the first step and the last step, which are immobilization and treatment delivery. Immobilization means before radiotherapy we make a tiled mold for the patient so that the patient's position remains consistent during subsequent treatments. Simulation positioning uses imaging scans like CT or MRI to acquire internal body images, and therapists make marks on the patient's skin or mold to ensure that during each treatment, the body position can be precisely replicated. Treatment delivery is what we commonly call machine treatment. Once the radiotherapy plan is designed and passes the plan verification, the doctor will arrange for the patient to be positioned and treated. My daily work is quite trivial and also very fulfilling. Simply put, I need to keep an eye on 3 places: the radiotherapy ward, the radiotherapy outpatient clinic, and the Proton Center, and guard 2 lines: quality and safety. And do one thing thoroughly: focus on the patient's physical and mental well-being, from admission assessment to condition observation, specialized nursing, and so on. Our case managers actually help patients smooth out things on their treatment path before they even arrive at the hospital. They don't know the hospital's procedures, so I list them all in detail for them, solving their problems until we have actually paved the way for them. When they first arrive at the hospital, I will tell them in advance, call me when you arrive, and take them step by step to see the doctor, and then go for other examinations during the treatment. I will visit them every day, so that they feel they are not carrying it alone, but rather someone is accompanying him. When returning home from the hospital, actually he is very afraid of the patient being neglected. In the later stage, we will follow up continuously to remind them to go for re-examination. Are all done very standardly from the beginning after the patient arrives. For example, whether they are suitable for proton therapy. The department will organize a case discussion to decide, and for some patients, we even invite surgery, imaging, and pathology to organize a multidisciplinary discussion together. If they are suitable for it, then we enter the phase of treatment. Our doctors do a relatively good job in patient immobilization in this area. We made this plan during planning. The physicist has made it. We also have a P2 discussion for the radiotherapy plan. Doctors, physicists, and technologists, we discuss that plan together to see if it meets our requirements, where improvements are needed, even during the treatment process. We will not only base it on the marking lines drawn on the body surface or a cross on the mask for positioning. We will also perform a CBCT or KV imaging verification until the anatomical landmarks or the scope of the tumor are aligned before we start the treatment. So under such circumstances, our requirement for head and neck setup error is within 3 millimeters. We often have only 1 millimeter or 2 millimeters, and for chest and abdomen the requirement is within 5 millimeters. We often have only 2 to 3 millimeters. Under such precise conditions, so we manage the entire process, achieving precise positioning, precise plan design, precise treatment delivery. We call it a triple precision treatment. We encounter many breast cancer patients during treatment who have breast implants. In cases like this, we will contact the manufacturer to obtain detailed information about the implant, including materials and dimensions. We will contour it and assign its physical properties to ensure precise dose calculation and plan optimization. Any changes in patients during the treatment process will affect the beam range and dose distribution of the original plan, so we will perform a comprehensive evaluation. As long as the change has sufficient clinical impact, we will adjust and re-optimize the plan accordingly, which is adaptive planning, truly doing everything that should be done to ensure the plan is optimal, using more refined radiotherapy techniques such as gating technology, negative pressure technology, and DIBH phase. During the image verification process of radiotherapy, if we find the patient's intestinal gas or feces have increased, we will also help the patient vent gas unify in the treatment room, or let the patient get down to defecate. It doesn't sound like a highly difficult operation, but it is very time-consuming. To achieve precision, we feel spending this time on patients is very worthwhile. We are willing to take this slow effort for patients, as long as it benefits them. For patients receiving treatment, especially pediatric patients, and different groups such as elderly patients, we have developed personalized care plans. An elderly inpatient in our ward, whose condition was relatively complex, and who also had mobility difficulties. And with the long-term treatment, their mood had been relatively low, in addition to providing our professional care, more about providing companionship and psychological support, gradually becoming willing to actively communicate. Family members told us touchingly, being hospitalized in your department, we feel especially at ease and very secure. No matter if you have different identities, status, nationality, or age, actually in the face of illness, everyone is the same. They also have their most vulnerable side, and we are the ones standing by their side. Case managers should make others think we are the most reliable friends. And also the hospital's person you are most familiar with, to let patients receive treatment with peace of mind and recover with confidence. That is the meaning of existence for our Proton escort team.